sonography in trauma. The indication is the acute blunt or penetrating trauma, trauma in pregnancy, pediatric trauma, subacute trauma with unexplained hypotension. The goal is to identify the free fluid which is appear as anechoic in a location where it doesn't normally belong and to detect the visceral injury. The advantage of the FAST scan, it can be performed within 5 minutes, it's non-invasive, can be repeated, it have the same sensitivity and specificity for detection of the free fluid as diagnostic peritoneal lavage and CT. Disadvantage, it's the operator dependent, may not identify the specific injury such as haloviscous bowel or retroperitoneal injury. The obesity and subcutaneous air, bowel gas may interfere with the examination. The FAST consists of 4 basic examined areas: is subxiphoid or subcostal area, right upper quadrant area, left upper quadrant, pelvis. 3 to 5 megahertz is best utilized as multi-purpose probe. We have the standard views and the extended views. The standard views is in subxiphoid or subcostal for examination of pericardium, right upper quadrant for examination of the Morrison pouch, left upper quadrant for examination of splenorenal and perisplenic space, the pelvis for examination of cul-de-sac and pouch of Douglas. The extended views is for examination of the pleural effusion or hemithorax. Now we have subxiphoid examination. We put the probe subcostally below the xiphoid process and we examine the area which showing the appearance of the liver at the top of the screen and the 4-chamber view of the heart. Very important not to mistaken the epicardial fat pad, which is appear as the thin layer of fat appear anterior to the right ventricle and not present below the left ventricle. Is very important not to mistaken it as the fluid. This is the FAST scan for the subcostal area showing pericardial effusion. And another scan showing also pericardial effusion in post-traumatic patient. Right upper quadrant examination, the probe is placed perpendicular in mid-coronal plane, superior to the iliac crest, facing toward the patient's head. The normal anatomy showing the liver at the top of the screen and the kidney with the hepatorenal space or Morrison pouch in between. This is the FAST scan showing the fluid within the Morrison pouch. Another patient, also post-traumatic, showing fluid within the Morrison pouch. Left upper quadrant examination, the probe is placed at the same plane to the right upper quadrant, but the normal anatomy is slightly different. The left kidney is more superior than the right, is more difficult in evaluation than the right upper quadrant. It's used for evaluate the fluid within the splenorenal and perisplenic space. As we are seeing, this is the spleen and the kidney, and we can see any presence of any fluid within the perisplenic or splenorenal space. As we are seeing in these cases, this is the fluid within the splenorenal and perisplenic spaces. Pelvic examination, the probe is placed transversely, then longitudinally in midline 2 cm superior to symphysis pubis. The probe is facing toward the patient head and slightly to the right side. The bladder is better contain some urine. Evaluate the urine and bladder and the uterus in female and the prostate in male. This is the longitudinal and the transverse view for the normal pelvis, and this is the fluid within the cul-de-sac. Extended view, we have the previous view. This is the basic view or standard views. The extended view is check for the diaphragm for the hemithorax. The probe is placed cephalic and slightly longitudinal. Chest X-ray is less sensitive than the ultrasound in detection of the hemithorax. It needed about 50 to 175 cc to be detected by chest X-ray versus the 20 cc detected by the ultrasound. And now we have a new protocol for evaluation of the thorax for detection of pneumothorax by FAST. This is the hemothorax detected by the FAST scan. Now the FAST for detection of pneumothorax, the high frequency 5 MHz probe is preferred, placed in the second or third intercostal space in midclavicular line, in a sagittal orientation, moved inferiorly in oblique fashion. The normal lung ultrasound, it have two findings, a sliding lung sign and the A lines. A sliding lung sign is the echogenic line representing normal visceral and parietal pleural interface, and the A lines representing horizontal line represent reverberation artifact originating from hyperechoic pleural line, is equally spaced, extend for short distance, decrease in echogenicity when descend downward. As we are seeing in this normal lung ultrasound, this is the echogenic pleural line, and this is the A line, which represents reverberation artifact from the pleural line, and it's equally spaced, decrease in echogenicity as descend downward and not extend for long distance. In M mode, the normal lung ultrasound producing what's called seashore sign. We imagine that the area above the pleural line as the sky, and the pleural line is the seashore or Sahel al-Bahar, and the reverberation artifact below the pleural line is reasonable to the sand, so that it's called seashore sign. B-line or comatal artifact is the hyperechoic vertical line extended from a pleura to the edge of the screen. The comatal artifact moves with the lung sliding and with respiratory movement. It's very small in normal lung, but prominent in consolidation and pulmonary edema, so that the traumatic patient considered to have pneumothorax by FAST scan if there is absent a sliding lung sign. Pleural line is still present, but it's not moving with respiration. And the A line may be present, but more numerous and not equally spaced. The B line are no longer present. Visualization of the B line with absent sliding lung is not diagnostic of pneumothorax, as the B line usually are never present with pneumothorax. If they present, it's indicate not moving lung, but the lung is diseased. As I mentioned previously, the B line are prominent in some disease such as lung consolidation or pulmonary edema. The pneumothorax, it is producing what's called barcode sign or stratosphere sign in M mode, which represent the destruction of the normal lung anatomy as appeared in ultrasound. The lung point, the junction between the normal and the abnormal lung, is called the lung point. When it's seen, it's 100% diagnostic of the pneumothorax. It can be used to estimate the size of the pneumothorax, as we are seeing in this ultrasound, showing the normal lung, and the other lung is contain pneumothorax, and the point between them is the lung point, which is 100% diagnostic for pneumothorax in ultrasound. Also, on FAST scan, we can detect pneumoperitoneum. The free air shift to the least dependent area of the peritoneal cavity with change in patient position, which is called shifting phenomena. When both free air, free fluid, and air are present in peritoneal cavity, producing peritoneal stripe sign. Non-dependent air appear as thickened echogenic peritoneal stripe with or without reverberation artifact. As we are seeing, this is the peritoneal stripe sign, which is represent echogenic line, represent the mixing of both a free intraperitoneal fluid and air, with the reverberation artifact in the other scan. Accuracy of FAST and the clinical decision making. Sensitivity is 69 to 98% for detection of a free fluid, and lower sensitivity is 63% for detection of solid organ injury. Underestimation of the injury and severity, especially in stable trauma patients without detectable free fluid. High specificity, about 94 to 100% for detection of a free fluid and or solid organ injury. Serial FAST examination increase overall sensitivity to 72 to 93%. Now, how to interpret FAST? The FAST is considered positive if there is a fluid within pericardium or any one of abdominal window, and considered negative when there is no fluid in any window, and considered indeterminate if any one of the window is inadequately visualized because the patient posture or unconsciousness or whatever the cause. Now we have what's called a scoring system of a fluid. 1 point is assigned to each anatomic site in which free fluid is detected during FAST scan, with a score ranging from 0 to 8. Fluid of more than 2 mm in depth in hepatorenal or splenorenal space was given 2 points instead of 1. Floating loops of bowel were given 1 point. 96% of the patient with score 3 required exploratory laparotomy, while 34% of the patient with score less than 3 still require surgery. As we are seeing in this diagram, this is the Howing fast scoring system. The fluid in each pouch is given score 1, except in case of it is more than 2 mm in depth, it's given score 2. So that after calculating the score, the number of score decided the possibility of the presence of the intra-abdominal organ injury and the need for surgery. As we are seeing in the left diagram, the patient with score 1, for example, it have the possibility for the intra-abdominal organ injury about 59, and 13% of them need surgery. While the patient with score 3, it have the possibility for the intra-abdominal organ injury about 83%, and 63% of them it need the surgery, so that the Howing scoring system is very important for the decision of surgery and detection the possibility of the presence of intra-abdominal organ injury. The scan should be repeated during the secondary survey and also if the patient demonstrates clinical deterioration, since the free fluid may have accumulated in the intervening time. The quality of the image option may be also have limiting factor, such as obesity, gas within bowel, pre-existing fluid collection as ascites and dialysis, a fluid in bowel loop, subcutaneous emphysema, non-mobile patient, and penetrating injury. All these factors represent the limiting factor of the FAST scan. Now, how to approach the FAST scanned patient? The stable patient with FAST negative need observation, while the unstable patient with FAST positive needed immediate surgery. As we are seeing in this diagram, the FAST scan patient depend to hemodynamic state of them. FAST scan in stable hemodynamic patient, if it is negative, needed observation with serial examination, while if it is positive, it needed further evaluation by the CT scan, even need immediate surgery within the operating room. FAST scan in unstable hemodynamics, if it is negative, it needed to searching for other extra-abdominal organ injury or even needed diagnostic peritoneal lavage, while in case of positive FAST scan in unstable patient needed immediate surgery and the patient must go immediately to operating room. If the FAST scan is equivocal or indeterminate, also we depend upon the hemodynamic state of the patient. If it's unstable, so that immediate surgery is the opinion, while if it is stable, also we can repeat it, the ultrasound, and after that we can decide it and never forget the hemodynamic state of the patient. Now the question is, does the FAST scan replace the CT scan? The CT scan is far more sensitive than the FAST for detection and characterization of the abdominal injury in trauma, but it never sends, very important, never to send an unstable patient to CT scan. As we know, the FAST scan is the rapid, time consuming, and can be performed in traumatic patient and during resuscitation. All these factors cannot be performed with CT. In this diagram showing the difference between the FAST scan and CT in accuracy for the detection of hemiperitoneum, which is 88% for the FAST scan, while in CT scan it's 100%. The accuracy for detection of the solid organ injury is about 74% in the FAST scan, while in CT scan nearly 100%. The missing rate for detection of hemiperitoneum in FAST scan 15%, while this possibility is not present within the CT. And 25% of solid organ injury is missed within the FAST scan, while within the CT scan is not present. So that the question is the CT is superior but cannot be used with an unstable patient, so that the FAST scan is used with a stable and unstable patient and is best bedside investigation to be done in a traumatic patient. FAST can also detect the solid organ injury The sonographic pattern of solid organ injury is contusion. It appears as the partial defined nonlinear echogenic area. Subcapsular hematoma, it appears under the capsule. Intraparenchymal hematoma, it is appear as a well-defined rounded hyperechoic area. The laceration, it appear linear, well-defined hyper or hypoechoic area. Multiple laceration vascular injury may indicate organic fracture and disorganization. As we are seeing in this FAST scan in liver injured patient, detect the liver laceration and intraparenchymal hematoma. Another post-traumatic patient, detect the subcapsular liver hematoma by the FAST scan. This is the intraparenchymal hematoma within the liver and liver laceration as detected by CT in traumatic patient. This is the splenic laceration detected by the FAST scan and confirmed by CT. Subcapsular splenic hematoma detected in patient, post-traumatic patient. Another patient with splenic laceration confirmed by CT scan. This is the renal laceration as detected by FAST. And this is the renal subcapsular hematoma. And thank you.
شكرا جزيلا عاشتي دكتورة